Hello, I'm Dr. Stogicza. I practice at University of Washington in Seattle. I'm going to talk about prolotherapy, which is kind of an old-fashioned therapy that's coming back to be trendy again. It was invented in the early 1900s, but somehow it fell out of favor. However, now, although we have a lot of standard therapies, we don't seem to be able to solve every problem. So we are reaching back again to prolotherapy, and there are more and more practitioners doing prolotherapy, I find. I learned this technique in the United States, and I brought it back to Budapest. And we've done, because it's very cheap, we've done a very large number of patients. So we have lots of clinical experience with this. In brief, what is prolotherapy? It is absolutely the opposite of every standard techniques. With the standard techniques, we are focusing on standard interventional techniques. We are focusing on calming down the inflammation. We're putting steroids. But we are not addressing the real issue, which is often an underlying instability. Whereas with prolotherapy, we are trying to identify where the problem joint, problem ligament is, and then we're trying to get it regenerated. So it is falling in the category of regenerative medicine. I would say it requires a very similar thinking as using platelet-rich plasma or stem cells. We are injecting to the same targets. It requires the same understanding of what went wrong. Why is this joint hurting? And then we inject Prolo solution. The good thing about it is that it's very cheap, so it's accessible in poor countries easily. It only uses sugar, phenol, and glycerin. Some places they do only sugar, or there are different variations of solutions. But it's also kind of the downside that it's cheap, so there's very little industrial support for it, right? So I thought I would walk you through a case and how prolotherapy can help. So many of us see patients who had a car accident. Usually they were rear-ended, young women. They had no loss of consciousness. They didn't hit their head. Nevertheless, a few weeks after the car accident, they develop a devastating, constant neck pain, headache, a pain that comes from the back of the head, wraps around the head. And very often these women tend to lose their jobs. They're unable to look at the computer anymore. They become seriously disabled. Now, when they go to the ER, everything is negative, obviously. They get an MRI, it's all negative, and these are I would say, very complicated patients that everybody thinks they are a hot mess because they hurt everywhere. They don't even know where to start. And they only really have a ligamentous injury from the car accident, and everything else is kind of building up on it. When this patient comes to us, we think of what is hurting. It can be, of course, it can be the facet joints with the ligaments, it can be the musculature, and the nerves as well. And often it is the case that all of these components are actually taking part in this very complicated clinical picture. Think of something easier for a moment. Everybody understands when we twist our ankle, we all know we have a ligamentous injury, right? That's why our ankle will be prone to twist again. You roll your ankle, it's going to happen again. But that's a very simple anatomy, which is why it's all recognized. I see cervical spine is a much more complicated anatomy, but the cervical ligaments, just the same way, get injured if they have a high impact from a car accident, for instance. So on this cartoon, you can see how the ligaments are ruptured, or better said, probably loosened. They're not holding so well in the cervical spine anymore, and that leads to a variety of pathology. The first thing is that injured ligaments hurt, right? Again, think back to the ankle. An ankle injury hurts. The same way, cervical facet ligaments pain will give pain to the patient. Also, as Bogdak studied, cervical ligaments refer pain, so there is going to be a referred component of the headache that's still purely coming from the facet injury. Now, on top of that, because the patients hurt in their neck and because they often lost some of the stability, they're going to experience, all of them actually, without an exception, increased muscle tightness, and they will say, oh, it's tight everywhere, it hurts everywhere. And that is a consequence of the underlying facet problem, ligamentous problem. Now, we all understand that once the muscles are tight, they don't have a good blood circulation, and therefore they will again add to the pain. So the clinical picture is getting more complicated. And we also know and commonly understand that nerves go through muscles. So often, for instance, with the tight cervical muscles, we would develop an occipital neuralgia, which is well understood and treated. But that is just the peak of the iceberg. So if we treat the occipital nerve, if we treat the muscles, we're not addressing the underlying problem. Of course, we should not forget about the standard therapies, because we can deal with the facet by nerve blocks and doing radiofrequency ablations. But it's not increasing the stability. It's just taking away the nerve-feeding pain information. So when we do prolotherapy, our target is all these ligaments and facet joints that are not so stable, and we will stick the needles to these injured ligaments. And the main concept is we are creating an inflammation. We are not putting steroid to calm down the inflammation. We want the body to have a good inflammation. It's like a controlled burn, and regenerate through the inflammation new tissue. Again, there is good and bad things about it. It's not going to be an immediate solution. I always explain patients, don't expect to go away pain-free. It's a process because you're building your new own ligaments. So in the first picture, this is a lumbar spine, which is just the most commonly used cartoon for prolo. This patient probably lifted something heavy, felt a pop, and ruptured the lumbar ligaments. And the second image, you'll see that we will inject everywhere where we clinically diagnose that there is a ligamentous injury, and it's often based on palpation and understanding the mechanism of injury. And in the third picture, you would see how we regenerated ligaments, we regained structure. Therefore, once we fix the underlying problem, there will be no reason for the muscles to go constantly tight and spastic. So fixing the whole problem from the bottom of the iceberg, we take away the pain components. When I do prolotherapy, I usually do 3 series, injecting everywhere where I think there's a ligamentous problem. And I do this series every 2 weeks. And I always tell my patients that after the 3rd set of injections, they have to have some benefit. They have to be either more stable or less headaches, less frequent headaches, or less severe headaches. They have to say that they are benefiting some. Otherwise, I have to rethink the diagnosis or reevaluate the whole clinical case. But if they do benefit, then I do another 1 or 2 sessions. So going back to our patient, which is this young woman with the constant debilitating headaches, if she comes to me, I would put her through a treatment, quite a treatment. I would focus on addressing the muscle, the myofascial component, and that's the usual thing, physical therapy, trigger point injections, or IMS and hot bath. It's not fixing the underlying problem. But then I also, parallel to the muscle treatments, I do prolotherapy. And here is this picture showing, for example, where I would stick my needles. In this patient's case, for example, I would identify if it's C4, 5, 6 facets injured, and then I would put needles from a nice and safe posterior approach to the cervical facets, affected cervical facets, and inject my prolotherapy solution. Let it be just sugar or a glycerin, dextrose, phenol combination. What I often find as a problem that prolotherapy is practiced by a lot of practitioners, and it's a bit, I would say, abused. I hear patients undergoing 10, 20, 30 prolotherapy treatments, which is, I think, it's a terrible enemy of the therapy, because if someone needs 20 treatments, it's clearly not going to the right area. The prolotherapy does have a very wide area where you can apply it, basically on every ligamentous injury and every tendon endothopathy. The most common application is, for instance, tennis elbows or golf elbows, and those are the lower risk areas where I think one prolotherapist should start when getting into prolo. Or another lovely application is SI joint, also very safe, often of course accompanied by piriformis attachment, but you can work on the knees, on hip or shoulder. So it's a very wide application. I sometimes say that if I had one tool to take with me to deal with pain, then it would be prolotherapy. Is addressing an instability. It's falling in the category of regenerative medicine. It's cheap, much cheaper than PRP or stem cells, and it does give a patient a chance to go from scratch.